Hi, in this video we'll talk about an important topic for each radiologist generally and especially for radiologists who working with oncology and dealing with CT as abdominal studies. This topic is imaging approach of hypervascular primary focal liver masses by multi-detector CT. This topic will be divided into two main parts. Part 1, which will covered by this video, and we'll talk about two main important items. The first item is optimum technique, and the second item is some important terminology to understand how the focal lesions dealing with the contrast injected to the liver. Additionally, in the second part, we'll discuss in details the cardinal features of the common benign and malignant lesions, and we'll know how can we discriminate between them, and we'll apply a stepwise algorithm and stepwise clinical approach to reach to the final diagnosis, or at least a narrow list of differential diagnosis. So the learning objectives for this video: upon completion, you will be able to use and know the optimum technique for the liver imaging by CT, and you will know the different phases and what are the importance of each phase for focal liver lesions characterization. Also, you will understand the different concepts and terminology of the enhancement pattern of the liver lesions, which plays an important role for these lesions to be characterized and to reach to the final diagnosis. So let us first talk about the hepatic blood supply. As you know, the liver receives the blood supply from two main sources. The first one is hepatic artery and represent 20%, and it carries the oxygenated blood from the general circulation and deliver it to the liver parenchyma. The second source is the portal vein, which represents the 80% of the blood delivered to the liver, and it carries deoxygenated blood and the nutrients from the GIT and deliver it to the liver. If we check this diagram, we'll find that the hepatic artery by the red arrow receives the blood from the body and general circulation, and it carries the oxygenated blood and it delivers it to the liver. While in the portal vein receives its blood from the GIT and it carries deoxygenated blood and a nutrient supply from the absorbed food and deliver it also to the liver. While the venous drainage of the liver comes to get out from the liver and drain into the IVC. And this diagram illustrating how the liver receives its blood from the two major supply. Hepatic artery represents 20% and portal vein represents 80%. Now come to the ideal technique of the liver CT of the liver examination. Ideally, the ideal technique should contain 4 phases of imaging. As you know, the commonest to say there is a triphasic CT of the liver study, and these triphasic, it means 3 phases which represent a post-contrast phases after contrast administration. But I'd like to call it quadriphasic because the non-contrast or unenhanced phase is very important to perform, especially when you will image the liver for the first time. So you have a non-contrast unenhanced CT phase, then you will inject the contrast and you will image in the arterial, portal, and delayed or equilibrium phases. In the arterial phase, it means that you need to examine the liver parenchyma after the contrast gets out from the hepatic artery. You need to examine the part of the liver parenchyma supplied by the hepatic artery. In the case of the portal phase, you need to examine the liver parenchyma supplied by the portal vein. And in the late phase, you need to examine the part of the liver after the washing out of the contrast. If we ask a question, what's the optimum arterial timing for detection of hepatic focal lesion? And we have two options, late arterial and early arterial. So what do you expect the right answer? Late arterial, it means that about 35 seconds, while the early arterial about 18 to 20 seconds. So is that difference between the late arterial and the early arterial? Is it important to determine this time, or it doesn't matter? So let us check this example to help you to select the right answer. We have a patient imaged twice at 18 seconds and 35 seconds. At 18 seconds, which is the early arterial phase, we can notice that the liver parenchyma is not completely enhanced. It's hardly to see the contrast. While we can visualize the hepatic artery, which is indicated by the yellow arrow. So the hepatic artery is still full with contrast, while the liver parenchyma, it's not received an optimum dose of contrast yet. If we come to at 35 seconds, we'll find that the hepatic parenchyma almost enhanced and the hepatic artery almost deliver its content to the liver parenchyma. And we can realize the huge difference between the two images. There is a large lesion and multifocal lesions occupied by the occupying the right liver lobe. All these lesions and its extension were not obvious at the early arterial phase. So you can detect the difference between the two phases, and you can select and you can say that late arterial phase is the optimum phase for imaging of the focal liver lesions, because you need to examine the liver parenchyma after the contrast has received for it. While in the early phase, you can notice that it's optimum for assessing of the hepatic arterial supply, hepatic artery, but not suitable for the hepatic parenchyma. So the right answer of this question is the optimum arterial time to scan the liver is, in case of focal liver lesions, is the late arterial phase. Okay, let us take an idea about the commonest indication of early arterial scan and late arterial scan of the liver. Regarding early arterial scan of the liver, usually we can use it during the preoperative assessment of the procedure of liver transplantation. In such case scenario, you need assessment of the arterial anatomy and the hepatic artery and its branches and their divisions to know actually how can the surgeon deal with the anastomosis. So it's important to do the early arterial phase during hepatic transplantation procedure. On the same time, you need a late arterial phase to assess the liver parenchyma itself. So during liver transplantation, you need both scan time, early arterial and late arterial. Also, in case of would like use chemoembolization of the liver tumor, you need to check if the tumor is still there is with vascularization, and you need to know the arterial roadmap, how can you install the chemotherapeutic agent to the target lesion. So you need to know the hepatic arterial anatomy. On the other hand, the late arterial phase usually used to characterize the liver lesion, especially when it is first time imaged, the first diagnosis. Also, it could be as a screening for cases, suspicious cases of cirrhotic liver with high alpha serum protein. So you need to make early diagnosis. You will need to take assessment of the hepatic parenchyma, so you will do late arterial phases. In case of suspicious of hypervascular metastasis, some tumor give hypervascular metastasis to the liver parenchyma, so you need to make assessment and the proof this is and metastatic deposits of the liver, as in case of melanoma or renal tumors. Thus, the answer of this question is the optimum timing is the late arterial phase, about 35 seconds, as we discussed earlier. What about the rate of injection? The rate of injection of contrast media usually use the optimum rate with average 3 to 5 millimeter per second, and try to use the 5 millimeter per second as you can, especially in the case of liver cirrhosis, because in the cases of liver cirrhosis, the hepatic vasculature is not healthy, and the hepatic vascularity affected due to the fibrosis in the liver parenchyma. So it's better to use the maximum dose as you can, with the best as a 5 millimeter per second. So what about the portal phase? Portal phase, the optimum time is 75 seconds. And here there are some examples of the variation of lesions you can find it during this phase. You may find the hyperdense lesion as this one. It's hypervascular compared with the liver parenchyma, or you cannot find an obvious lesion and there is a subtle one, especially if there is a liver cirrhosis. We can notice this is a circle here. This is the site of the lesion, which is almost isotense to the liver parenchyma, so it is not so obvious. Or in another situations, you can find hypodense lesions compared with the liver parenchyma. So these are a different patterns of focal lesions. You can identify it during the portal phase. Regarding delayed phase, the optimum time is 7 to 10 minutes. And also there are variations of lesions. You can find it in the delayed phases. In the delayed phases, you cannot find any lesion. The lesion became isotense. You cannot characterize any lesions differ than the liver parenchyma. Or you can find the lesion in the delayed phase hypertense, like that one, or you can find the lesion more hypodense than the liver parenchyma and give hypodense pattern. All these variations will be discussed later in details. So in summary of the technique of the liver tumor, if you're dealing with initial diagnosis, a case you need to make a diagnosis for the first time, so you need to do the optimum study, quadriphasic study, non-contrast CT, late arterial phase at 35 seconds, portal at 75 seconds, delayed at 10 minutes, and remember that the rate of injection, the optimum is 3 to 5 milli per second, and 5 millimeter is the best as you can. However, not in every case scenario you need to do the typical 4 phases. In some cases which already diagnosed and they came for follow-up, you can be satisfied with the venous phase, especially in the case of follow-up of the tumor, as in the case of metastasis. You need to follow up the size of the tumor as a treatment response, especially when you are dealing with RECIST criteria 1.1, may be discussed later. Also, in case of HCC chemoembolization, after chemoembolization of the target lesion, you need to assess this lesion, especially in the arterial phase. So here, the arterial phase also is important, because you need to know if there is still vascularity of the target lesion, is still vascularized or not. Another case scenario during liver transplantation, as we have discussed later, you need complete study. And in addition, you need early arterial phase, because this will give you the hepatic arterial anatomy, give you an idea about the hepatic arterial anatomy and its detail, in addition to give you an idea about the liver parenchyma. So in the follow-up, according to the case scenario, you may need a complete quadriphase CT, or you may satisfied by one phase, as in the case of the follow-up of metastatic tumor by venous phase, or in chemoembolization assessment and follow-up, you can satisfied by the arterial and the venous phase. Now let us discuss an important concepts and terminology used in description of the hepatic focal lesions, and they are very important in lesion characterization. These are three terms: hypervascular lesion, hypovascular lesion, and washout pattern. When we can say this lesion is hypervascular or hypovascular? When can you say the patient this lesion has a washout pattern or not? This is very important to know and very important to understand. If we check this example, the first one on the left side, these examples are taken at the late arterial phase, so this is the optimum scan time as we discussed before. This image, we find that the right liver lobe has a lesion, relatively small one. This lesion has a significant enhancement, and when you compare its enhancement with the normal remaining liver parenchyma, you can definitely say this lesion takes enhancement more than the liver parenchyma. It means takes a large amount of contrast compared with the normal liver parenchyma. This means that this is a hypervascular mass lesion. So the rule here is to compare the enhancement or the density of the mass with the remaining liver parenchyma. If you find the mass lesion take enhancement more than the liver parenchyma, this means that you are dealing with a hypervascular mass. If we apply the same rule on the second example here, you can find that there is a large mass almost occupying the right and the liver lobes. And this mass, referred to by the red arrow, its enhancement and its density, it's higher compared with the normal liver parenchyma. So, according to our rule, this is a hypervascular mass. So, you are dealing with a hypervascular mass. So, the meaning of hypervascular mass and the clue to determine is it hypervascular or not is to compare with the normal remaining of the liver parenchyma. On the other hand, if we check these two examples, this on the left side, you will find multiple small lesions. Their enhancement pattern and their density are less than the normal intervening liver parenchyma. Also, in this example, you find a large mass which is hypodense and its enhancement very significantly low compared to the normal liver parenchyma. So, here, definitely we can say they are hypovascular lesions. Hypovascular lesion. Why? Because their enhancement and their density is less than the normal remaining liver parenchyma. So these are the definitions. How can you know the hypovascular and the hypervascular mass lesions? So why is it important to differentiate between the hypervascular mass lesion and the hypovascular lesion? Simply because when you are dealing with a hypervascular mass lesion like this case, you have a differential diagnosis completely different from the list of differential diagnosis of the hypovascular mass lesion. Additionally, the differentiation between those type of enhancement is one of the important steps in our differential diagnosis algorithm, which we will discuss it in the coming video. So remember that hypervascular or hypovascular, the clue is comparison between the enhancement pattern of the lesion and the enhancement pattern of the normal liver parenchyma. Okay, the last concept I'd like to discuss with you is the washout concept. What's meant by washout and how can check it? If we check this case, we have a case on quadriphasic CT, non-contrast CT, late arterial, venous phase, and delayed phase. So in the non-contrast CT, there is no obvious lesion, while in the late arterial, there is a small, well-defined lesion which takes enhancement more than the liver parenchyma, so it is by definition hypervascular lesion. In the delayed phase, the lesion not so obvious, become isodense, we cannot see anymore. And in the delayed phase, the lesion became hypodense compared with the liver parenchyma. So what's happened here? In the case of hypervascular lesion in the arterial phase, the lesion well defined and it can be easily seen. In the venous phase, the remaining of the liver parenchyma take enhancement and receive the contrast from the portal vein. So normally, the degree of enhancement of the liver parenchyma is increased compared with the degree of enhancement of the liver parenchyma in the late arterial phase. So this means that the density of the liver parenchyma became equals to the density of the hypervascular lesion, so their densities become equal, so you cannot see the lesion in this phase. While in the delayed phase, the lesion wash out its contrast rapidly more than the rate of washout of the liver parenchyma. So definitely this hypovascular or hypoenhancement pattern here is called washout. So the washout by definition means that the lesion which is almost hypervascular get rid of its contrast rapidly more than the liver parenchyma. And it will be more obvious in the delayed phase. It could be the washout start earlier in the venous phase, but usually the most phase could be characterized, the washout is the delayed phase. So if we ask ourselves if this lesion has a washout, definitely has a washout. Is this lesion, which phase I can determine is this lesion has washout or not? The delayed phase. This is the optimum lesion. Some of the junior colleagues almost has a confusion regarding what's happened in the venous phase, and usually they call the lesion fade out and has a washout if we compare it with the arterial phase. But this is not the true, because as I mentioned, the density of the liver parenchyma increased to become equal to the density of the lesion, so the lesion become not seen anymore. But there is no washout at this phase. When you like to express this in your report, you write that there is a hypervascular lesion in the late arterial phase and the lesion became isodense to the liver parenchyma in the venous phase and has a definitely hypodense and do wash out in the delayed phase. This is another example of another case to more explanation of the washout concept. Also, there is a quadriphasic CT, non-contrast, arterial phase, venous phase, and delayed phase. Non-contrast, there is no obvious lesion, while in the arterial phase, there is a small hypervascular lesion, and we know that, and we know why it is hypervascular. In the venous phase, it became not visualized. This means that it became isodense to the liver parenchyma. In the delayed phase, also still the lesion almost isodense to the liver parenchyma, and there is no definite hypodensity as we have mentioned in the previous case. So the question is that lesion do wash out or not? Definitely you cannot say this is a washout. Why? You cannot see the lesion. The washout by definition, as I told you before, you should have a density less than the liver parenchyma and the most characterized in the delayed phase. You can see it in the venous phase, but both in venous phase and the delayed phases, the lesions almost became isodense. So this lesion has no washout, and this is very important in characterization of focal liver lesions, as we will discuss later. So let us check an example of hypovascular lesion. The previous two examples we discussed about the pattern of washout in hypervascular lesion. So what about if you are dealing with hypovascular lesion, as in this case? In this case, you find that the non-contrast CT, there is no obvious lesion, and in the late arteria also almost no obvious lesion, while in the venous phase the lesion is start here referred to by the green arrow. There is a little bit hypodense to the liver parenchyma, while it became more obvious, indicated by the arrow, the lesion definitely hypodense compared to with the liver parenchyma. And if we can notice that there is an enhancing margin or capsule of the lesion. So the question is that lesion has washout? Definitely we can say this lesion has washout pattern. Why? Because this pattern, the lesion became, its density became less than the remaining liver parenchyma. So it has a washout pattern. Despite that the lesion is not hypervascular, but you can say there is a hypodensity and there is a washout pattern because its density less than the liver parenchyma. So this is another pattern of washout, which is very characteristic for specific lesions, as we will discuss later. Finally, I'd like to give you home message at home. Remember that please, late arterial phase 35 seconds is the most important phase in characterization of the liver lesions to determine is it hypervascular or hypovascular lesion, and each type of enhancement has a different pattern of differential diagnosis. So it's very important to optimum the technique at this stage. Non-contrast CT is important, especially in the cases of liver cirrhosis and especially in the first time diagnosis. Hypervascular lesions means that lesion enhance more than the liver parenchyma in the arterial phase, while we can say hypovascular if the lesion doesn't take enhancement more than the liver parenchyma or less than the liver parenchyma. Washout means the enhancement of the lesion is less than the liver parenchyma in the delayed phase, and the washout can start early in the venous phase, but the optimum phase for detection is the delayed phase. Finally, I'd like to highlight the coming videos about the pattern of hypervascular lesions. The hypervascular lesions could be benign and malignant group of lesions, as we see in this slide, and we will talk about how can we differentiate and characterize them and what are the cardinal features of each of them, and we will apply an algorithm for differentiation and to reach to the final diagnosis, and we'll use what we learned in this video to apply this algorithm. So please keep in mind. Finally, thank you and see you in the coming video, the imaging approach of hypervascular liver lesions.